السلام عليكم. رمضان كريم ويتقبل الله. صف خامس إن شاء الله. محاضرة اليوم will be about primary amenorrhea. We have two lectures regarding amenorrhea. The first will be primary and the second will be about secondary amenorrhea. It is defined as the absence of menstrual cycles by the age of 14 with the absence of secondary sexual characteristics, or the absence of menstrual cycles by the age of 16 in the presence of secondary sexual characteristics. All the patients require investigation. In order to have a regular menstrual cycle, there should be a synchrony in the function of the hypothalamus, pituitary gland, and the ovary, which is known as the hypothalamic pituitary ovarian axis. If a problem happens at any level, it will affect the incidence of the cycle and probably the irregularity of the menstrual cycles. So in patients with primary amenorrhea who don't have cycles, there's a defect at one of these levels. And sometimes the defect could be anatomical, which we will talk about later. It is classified according to the cause as physiological or pathological. Physiological, for example, pregnancy. Pathological due to any of the disorders that will be mentioned in the upcoming slides. Or the amenorrhea could be classified as primary amenorrhea, where the patient hasn't had cycles, or secondary amenorrhea, where the patient has had previous cycles and then they stopped for more than 6 months. It could be a false amenorrhea, where the menstrual flow is collecting but it is not coming out due to an anatomical problem in the form of a vaginal septum or an imperforated hymen. Or it could be a true amenorrhea, where there is really no menstrual flow. And according to the workup plan, where the classifications are complementary to each other, it is physiological, anatomical, and endocrinological. The primary amenorrhea could be hypothalamic, where there's an absence of the gonadotrophin-releasing hormone etiology, or hypogonadotrophic, there is no LH or FSH despite a normal gonadotrophin-releasing hormone level. And the causes may be idiopathic, following radiotherapy to the brain, following surgery in cases of anorexia nervosa, those who practice excessive exercise, such as ballet dancers or gymnasts, chromosomal anomalies, congenital or anatomical defects, and probably tumors of the pituitary gland, such as craniopharyngiomas in childhood. From the endocrinological point of view, there are 4 subphenotypes, where it is classified according how we look at the patient, whether she has no breasts but a uterus is present, or the breasts are present and the uterus is absent, or both are absent or both are present. So the following classification will be according to these subphenotypes. In cases where the breast is absent but the uterus is present, when a patient comes, a lady brings her daughter, or a patient comes complaining from primary amenorrhea, we will check after taking a full history, examining the patient and investigation. If we find that the breasts are not present, however the uterus is present, it can give us a workup plan. We will send for an FSH level. If it is low, it means that that there's a problem at the hypothalamic pituitary axis, where there's a hypogonadotrophic hypogonadism. However, if the FSH is high, it means that the gonads are not responding to a normal hypothalamic pituitary axis. The problem is, for example, gonadal dysgenesis. Gonadal failure, where there will be a high FSH, can be seen in cases of Turner syndrome, mosaicism, deletion disorders, and congenital adrenal hyperplasia. Or it could be seen in cases of CNS problems, where the FSH will be low in CNS lesions, in Kalman syndrome, or isolated gonadotrophin insufficiency. Kalman syndrome is a condition where hypogonadotrophic hypogonadism is present, and the patient usually complains of anosmia or impaired smell, lack of the menstrual cycles, and maybe other associated defects. Those with Turner syndrome, it is a case where primary ovarian failure is happening, and a genetic disorder where there with abnormalities of the X chromosome. The karyotype is 45XO. The chromatin is deficient, and the other where the other X chromosome is absent, and the patient comes with short stature, as you can see, short stature, a fold here causing a webbed neck, a broad shield-like chest, wide carrying angles of the seen in the arms, poor breast development. She has scarce or absent axillary and pubic hair. The uterus is present, the vagina is present, the external genitalia appear normal. However, the ovaries are streak gonads, resulting in premature ovarian failure. So the hypothalamus and the pituitary will continue to produce GnRH and FSH. However, there is no response from the side of the ovaries, because they are streak ovaries, fibrotic tissue, and in those patients we will find high levels of FSH. Those will benefit from hormone replacement therapy. They can get pregnant by oocyte donation and hormonal support during pregnancy. They may also complain of other associated disorders such as coarctation of the aorta and renal anomalies. 99% of cases of Turner syndrome are aborted during at early pregnancy. Those who continue will be 1 in 2,500 cases, and their IQ is usually normal. Here you can see the difference between the classic Turner syndrome and the mosaic, where there is probably a normal development of the breast. The features are less clear. In cases of congenital adrenal hyperplasia, as you remember, we classified them into high FSH, Turner syndrome, and congenital adrenal hyperplasia. Here, the karyotype of the patient is an XX karyotype. She's a female. It has a recessive inheritance. The problem is that the baby, when it is born, the family will be surprised that the sex cannot be determined because of the ambiguous genitalia, and sometimes even during pregnancy, it is difficult to determine the sex of the baby by ultrasound examination. The vagina and the uterus are present, however, the ovaries are polycystic and unovulatory, and sometimes the adrenal cortex may be enlarged due to overproduction of corticotropic hormone. There's an increased adrenal androgen. That's why the teenagers, if it is late onset, will suffer from severe hirsutism and acne, and some neonates will develop a salt-losing syndrome. As you can see, ambiguous genitalia is apparent in cases of congenital adrenal hyperplasia. However, where the patient, the baby cannot be determined if it's a boy or if it's a girl, and that's why it will be sent for a karyotype at this age. Or, as I mentioned, severe teenage hirsutism and acne. In the second category, where when we examine the patient and we find that the patient has a breast but her uterus is absent, we will look for the karyotype. In the previous case, we looked at the FSH. Here at the karyotype. If her karyotype is that of a female, 46XX, then we will think that there is a problem, anatomical problem, which is the Mullerian agenesis, where we cannot find the uterus or it is just a rudimentary organ. Or if the karyotype was 46XY, we will start thinking of the androgen insensitivity syndrome, where the patient will have normal breasts and absent pubic and axillary hair. Regarding the anatomical, here, the Mullerian agenesis, which is the Myers-Rokitansky-Kuster-Hauser syndrome, 13 to 15% of ladies with primary amenorrhea complain from this syndrome. Their karyotype is 46XX. They have normal breasts, pubic and axillary hair, and female external genitalia. However, a normal lower vagina. However, the absent uterus and upper vagina, according to the anatomical development during embryology. The ovaries are normal. That's why they can get pregnant by they donate the oocyte, and a surrogate mother carries the pregnancy, so they can achieve a healthy child. They have a normal female range testosterone and other hormonal levels. However, they may have associated renal or skeletal anomalies. As you can see, this is a normal MRI of a normal patient, where you can see the uterus, how it is anteverted, anteflexed. This is the fundus, here is the cervix, and this is the vagina. However, here you can see that the uterus is rudimentary. It is not normally developed in cases of Mullerian agenesis. Here is a laparoscopic image. On the left is a normal laparoscopic image, the uterus and both left and right ovary. However, in cases of Myrick-Toniski-Kuster-Hauser syndrome, the ovaries are present, but the uterus is absent totally, or sometimes just rudimentary parts are found. The second is the androgen insensitivity syndrome, which is previously known as testicular feminization. Here, the karyotype is a male karyotype, 46XY. However, the phenotype is a female phenotype. The androgen receptors are lacking, which could be complete or partial. That's why that's why it's called the androgen insensitivity syndrome. There is androgen, however, there is no response to the androgen. The uterus is absent, the vagina is short. Also they have absent or scanty pubic and axillary hair. The testes or undifferentiated gonads may be abdominal or found in the labia majora. They have to be removed because they have a malignant potential. And the male pattern androgen levels can be seen. The third category, where the breast is absent and the uterus is absent, a patient comes with primary amenorrhea. When you examine the patient, you cannot find a breast, and the ultrasound tells you that there is no uterus. Patients in this group, they are rare, and usually they have a 46XY karyotype, and they require further endocrinological testing and treatment. In the fourth category, where the present breast is, she has normal breasts or present breast, and the uterus is also there, we can give them, we can give them a progesterone and treatment in the form of oral progesterone, injectable progesterone, and we will wait. If she has bleeding, it means that there's a problem with ovulation. Everything is normal, that except ovulation, where, for example, in cases of polycystic ovary syndrome, or if there is no bleeding, we give her a combined pill. Progesterone induces a bleed if there is an endometrium, an endometrial lining. In cases of PCOS, there is a high estrogen level, so the endometrium will be thick. So giving progesterone will induce a menstrual bleed. However, in cases where there is no endometrial lining, giving progesterone won't cause a bleed. So we try the combined oral contraceptives, where we give estrogen that will cause a thickening of the endometrium, and then we give progesterone, or it could be given together, and we will wait. If there is bleeding, it means that there's an ovarian failure. The ovaries are not responding to the normal hypothalamic pituitary hormones, and we check the serum FSH, we will probably find it high. However, if there is no bleeding, we will think of other factors, for example, anatomical factors. The diagnosis will be based on the history, appropriate history taking, examining the patient, usually with a chaperone, usually it's her mom, sending appropriate investigation and the diagnostic workup. Adequate history, that we have to ask the mother a thorough history. We have to look about the child have a growth spurt and development and other areas. What about the BMI? And we compare it with the height and weight charts of normal children. We ask the mom, when did your daughter start to have axillary and pubic hair? Usually they follow up their girls for looking for these. occurrences. And if she's having cyclic symptoms of menstruation, where I may think that, okay, there's no cycle, however, there are symptoms of menstruation, probably the menstrual blood is trapped above a vaginal septum or an imperforated hymen. And also, we ask her about herself, the mom, and other sisters, because it could be inherited. And and her sisters may have the same problem. It will ease diagnosis for us. Other points to notice in the history: if she has a chronic illness, trauma, surgery, medications, chemotherapy, radiotherapy, anorexia nervosa, if she's a ballet dancer, if she does excessive activities. Sexual history should be obtained because the patient may be sexually active and she may be pregnant, but she's afraid to tell her mother. And information regarding substance use or abuse, excessive exercise. What about the diet? Probably she's had a weight problem, and she did started doing a diet to control her weight. Home and school situations, psychological issues should be elicited. Symptoms such as vasomotor symptoms and hot flashes, which may tell us about ovarian failure. If she is having virilizing changes, where which include, hirsutism is hirsutism. There's an increase in the hair distribution in places that should not be in girls. However, virilizing changes include a breast atrophy, clitoral hypertrophy, muscular enlargement, and deepening of the voice. We will think of serious issues here. If she has galactorrhea, which means milk secretion coming out of the nipples, headache may indicate a CNS problem, fatigue, palpitation, nervousness, anosmia, and visual changes. Anosmia indicating Kalman syndrome, visual changes probably craniopharyngiomas. Pregnancy, I repeat again, could be the cause of primary amenorrhea, and so we have to determine if the patient is sexually active. You can be discreet. You don't have to tell it her directly. You can just send her for a pregnancy test among the investigations. This slide is beneficial in relating the history with the associations. For example, chemotherapy will lead to impairment of specific organ, the hypothalamus, the pituitary, or the ovary. Hirsutism, we may think of polycystic ovary syndrome, congenital adrenal hyperplasia, and it has been explained previously. Now we finished history taking from the patient, and the next step is to examine this girl or this lady, and we will tell her what are we going to do to the exam with the presence of a chaperone, which, as I previously mentioned, is most likely the mom. We ascertain the BMI of the patient. We look at the height and look at the weight. Probably if she's obese, relating to PCOS, or if she is too short, we can think of Turner syndrome. If there are signs of malnutrition or other chronic disease, we try to look for the pubic and axillary hair if they are absent, or on the contrary, if there's an increase in growth of hair growth, the secondary sexual characteristics, and examination of the breasts. We continue to examine the abdomen for probably palpable uterus or tumors, and the external genitalia is very important. We have to assure that the patient that it will be a simple examination. There will be no invasive measures. So especially girls with an imperforated hymen, they are usually very afraid. So we have to reassure the family and the patient. We check for the clitoris, the size of the clitoris, the normality of the hymen, whether it is an imperforated hymen, and we can notice the bulge of blood behind it, the hair growth in the pubic region. And as I mentioned, a bulging hymen may indicate cryptomenorrhea, congenital absence of the vagina or vaginal septum, and a blind vagina. If the condition of the patient allows, for example, she's sexually active, we can go for a speculum exam to look for atrophy, cervical abnormalities, excitation, uterine size, and pelvic masses through a bimanual examination. The Tanner staging, as I mentioned, we have to be familiar with it regarding to the breast development and regarding the TILARC in order to associate it with the age of the patient and her pubertal development. This is also, this table shows the association between the physical exam and the possible disorder. For example, the BMI, if it is high, it may indicate PCOS. If it is low, it may indicate anorexia or other problems. The stria, buffalo hump, central obesity, and hypertension may indicate Cushing syndrome, and so on. Now, what investigations are we going to send the patient, a patient with primary amenorrhea? We will send for a karyotypic examination. We will take the sample through a buccal smear to see if she is XX or XY or XO or other karyotypic configurations. We will send the pregnancy test, and as I mentioned, you can be discreet. You will send it to the other investigations and await the results. The hormonal investigation and hormonal profile is important in order to have a workup plan for the lady. The abdominal or pelvic ultrasound to see if there are any anatomical anomalies, if there are any tumors, if there are any absent organs, an MRI and X-ray also for further confirmation, and a laparoscopy. Sometimes we can go if the previous for a laparoscopy if the previous investigations are inconclusive. And here is the diagnostic workup plan. As I mentioned, in order to obtain a diagnosis, we have to take a history exam, investigate, and a diagnostic workup plan. Where we look for, it has been previously mentioned, we look for the secondary sexual development. If there isn't any, we will look for a constitutional delay of puberty, a chronic illness, and if there are secondary sexual characteristics and the pregnancy test is negative, we will give her treatment, progesterone, and we will wait for the bleeding. No bleeding, we can give the combined pill. The need of treatment will depend on the underlying cause, the need for regular periods, fertility, and need for contraception. I mean by this that we treat according to how the patient presents. She may know what's the problem. She has had a previous consultation, and she came to you to treat what she's complaining from. If she does not know the cause of her amenorrhea, we will treat the underlying cause. If she knows and she wants regular period, we will give treatment according. If she's married and she wants a baby, we will go according to that, and also we assess her need for contraception. Regarding the underlying cause, for example, if she had a pituitary tumor, let's go to remove it or give treatment in the form of bromocriptine or cabergoline. If there's an androgen producing tumor of the ovary, we will go for surgery. If there's testicular feminization, we have to remove the gonad to avoid an intra-abdominal malignancy, and we give hormone replacement therapy. However, they are sterile. They cannot have babies. Turner syndrome, we give hormone replacement therapy, and if they want a baby, okay, you will need an oocyte donation, and through IVF, in vitro fertilization, the embryo can be implanted in the uterus, and embryo transferred into the uterus, and pregnancy followed up with hormone replacement. And imperfect hymen, so simple, just to remove the surgical incision. However, culturally, it is difficult for the family. If there is a thyroid disease, we will give appropriate medical treatment. If she is having anorexia nervosa, we refer her to a psychiatrist. Polycystic ovary, we will tell her to reduce her weight, probably give her metformin, and so on. If she's trying to conceive, we may need ovulation induction if she's anovulatory. If the prolactin is high, we may need to give dopamine agonists such as bromocriptine or cabergoline. If there's a hypothalamic dysfunction, we will try to maintain a normal weight, meaning, for example, if she had a severe diet and she lost a lot of weight, we will try to normalize this weight and change her lifestyle if she is doing excessive exercise. If the patient just wants a regular period, we can use the combined oral contraceptive treatment or hormonal replacement therapy. If she needs contraception, if the ovaries have failed, she does not need contraception. You can go on having regular intercourse with your husband. Or if she wants an contraception, we will give her oral contraceptives. Thank you very much for your follow up. If you have any questions, please feel free to write on the class stream.